Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated.
And we have three very great speakers that we're going to hear from this morning. Doctors Jessica Roy, Paul Crabtree, and Krystal Kehoe Macleod. Our first two presenters will be Jessica and Paul. Jessica completed her medical school here at U of Ottawa via the Francophone stream at Montfort, followed by residency in family medicine at the University of Toronto. She then transitioned her practice over time to palliative care and received a CAC in palliative care through the college, and she provided home-based and hospice palliative care in West Toronto for 8 years before coming to Ottawa, where she now works at the Briere Palliative Care Unit and a consult for the Regional Palliative Care Consult Team. Her research and quality improvement initiatives are centered around access and equity of quality, compassionate care in the home setting, and increasing palliative care approach in primary care, community palliative care education, and also humanities in medicine. She is currently the Francophone palliative care expert for our UGME and is the QI lead for the Department of Palliative Care at Briere Health. Paul Crabtree completed his medical school here at U Ottawa in 1993 and residency in family medicine here at U Ottawa in 1995. He worked in the community at Meadowlands Family Health Center, providing longitudinal primary care from 95 to 2006. And as we all know, he then relocated to Primrose to join an amazing group of colleagues there. He enjoys family medicine and longitudinal primary care and is currently the medical chief of the Department of Family Medicine at Briere Health. Our second presentation will be by Krystal Macleod, and she's a postdoctoral fellow at the Briere Health Research Institute here in the University of Ottawa. She leads the Center for Care Access and Equity Research, where she and her team use community-based approaches to study barriers to care for linguistic and ethnocultural minority groups, the impacts of food insecurity on older adults, and Indigenous communities. At the role of integrated care models in meeting the needs of older adults with brain health interconnected conditions. So we'll start off first, Jessica and Paul. We look forward to hearing your presentation. Over to you.
Can you hear us and see the screen?
We can see the screen and we can hear you.
That's fantastic. Well, thank you kindly for that introduction, Doug. I wanted first to start off with a land acknowledgement. So I'll say that we acknowledge that we are on unceded and unsurrendered territory of the Anishinaabe Algonquin people, the land of the Anishinaabe Algonquin people who continue to live and steward here. I am of settler colonial ancestry. Although my heritage extends to England, I, like many settler people, have benefited from living on Single Island. As a settler, I feel a debt of gratitude to the Anishinaabe Algonquin people whenever I canoe on the lakes and the rivers around here. Their stewardship of the land over the years has allowed me to enjoy its beauty and bounty. I believe that it is not only important for us to recognize the Anishinaabe Algonquin people for their care and for their teachings about the earth and our relations, but also to honor those people through our interactions today and every day hereafter. With that, it's my pleasure to join with Jessica to present some opportunities that we have sort of realized together in providing home-based palliative care. And we're going to start with a mine, long-time patient of mine, and this is a 75-year-old female with multiple morbidities, struggling with cancer, close to gangrene and rest pain. She was very determined to be cared for at home, and it was becoming increasingly difficult to have her care provided in the clinic. She also had essentially angina with coronary artery disease, atrial fibrillation, and a history of wide complex tachycardia requiring cardioversion. Her hemoglobin was 80, iron deficiency. She did not want worked up. She was a type diabetic, firing, fluid control, and a history of DKA. She had a history of polymyalgia rheumatica, complicated by steroid-induced myopathy, so she was at high fall risk. Her social history was that she lived with her very supportive husband on one level of a home, accessible via the garage, and her daughter lived in the basement. They had a very strong Christian faith, and she did have a strained relationship with her son. This turned one call.
Sorry to interrupt, Paul. Would you be able to move a little bit closer to the microphone? It is still a little bit fuzzy. I mean, we're catching it, but it's a little bit garbled.
Oh, sorry. Can you hear better now?
Yeah.
Okay.
That's fine. Thank you.
Yeah, it's always the same. Get close to the microphone.
Yeah.
So basically, one call to the regional palliative care team turned this into a success story. With their assistance, we were able to better manage the patient's pain after initiating methadone as an adjuvant, low dose at night. He was a fall risk because of hypotension, so we stopped the nitroglycerin patch and it initiated nitro spray and tab PRN. He had dyspnea on exertion, and so palliative oxygen was initiated in the home. She had ongoing anemia and did not wish any further investigation or transfusions, and so we reviewed goals of care. We assessed risk reduction for diabetes management, and she tolerated sugars at higher levels in order to avoid hypoglycemia. We reviewed goals of care. She wanted a death at home, reviewed who to call, signed the DNR, and reviewed the expected death in the home or EDIS protocol. And then for about a year, we visited alternating visits between myself and RPCP until she was stable, and then RPCP signed off, waiting to re-engage when needed, and always a phone call away. So what is RPCP? I'll let my colleague describe.
Oh, this is the mic closer to me, and then that'll work okay? Oh, this is the mic. Oh, I see. Okay, well then I'm going to sit in my chair. So I work for the Regional Palliative Consult team, and just to let you guys know a bit about who we are. I'm hoping that some of you have worked with us, but we're a team of physicians, nurses, and nurse practitioners. And the nurses and nurse practitioners are specialized in palliative care. We cover the entire Champlain region. So when I tell people about that, it's like Barry's Bay to Hawkesbury along the Ottawa River, down through the St. Lawrence to about Iroquois, and jogging up along the park to meet the edges. So it's quite large. It's a partnership between Briere Health and Ontario Health at Home, which hopefully you guys know as like the WIN or all the other alternative names. Keep their head and watch it a while. And so what our mandate is really to support primary care providers, whether that's in the home, whether that's in a clinic, whether that's in long-term care, retirement home, in providing palliative care. And so it comes to with patient assessments, mentorship, phone calls, education programs, and it could be either consultative medicine or surgery. We serve an enormous amount of people over the years, and that's why the model has to remain shared care because of the volumes that we're seeing throughout the region. And so I'm really hoping that if you have your phones to take a screenshot of this, or if you're seeing this on YouTube, to do the same. But this is really an exhaustive list of how RPCT can be helpful in managing and like co-managing the patients who are appropriate for palliative approach to care. The ones that I want to highlight is the education and mentorship. We can do one-time consults and then just be available by phone follow-up, and we do a lot of this more in long-term care. We can also do shared care with alternating follow-ups, which I did with Paul. Also, we can help support joint visits with learners, such as residents or medical students from the clinic. Sometimes home care logistics can just be a little bit outlandish, lots of forms. How do I do this? Is this possible? So we can assist with home care logistics. And that being said, we are available 24/7 at a number that can be reached by a consultant. And then I want to highlight the blue box at the top, where we've really discovered, especially with the strain on primary care, that a lot of the concerns with working with RPCT came about with, getting phone calls in the middle of the night and what would we do if we got those phone calls? What if I'm not comfortable? And so we've now decided to take on the overnight phone calls from visiting nurses from 8 p.m. to 8 a.m. 7 days a week. Some new programs in our group also include doing paracentesis in the home. And so we have 2 skilled physicians, myself included, that do focus-based paracentesis in the home for those who have mobility issues getting to the clinic where they were previously getting paracentesis, or if it's a new need for paracentesis and they have mobility issues and don't have a program to slot into. And I'm really proud about the last one on the right, bottom right is ICD deactivation and home-bound patients. So this is a really new initiative that I'm working on as the heart institute, where we're going into people's homes where they can't get into the device clinic for ICD deactivation at end of life. Ideally not for imminent patients who are within 2 hours or 72 hours of dying. We can still suggest a diet on the test, but this is for those that their prognosis is increased. Okay, so with that, I'll go into a bit of statistics about what we know about home visits and why they're so important. But it's the number one thing is that home visits are good. So what we know about in primary care right now is that we're seeing that home visits in primary care providers have decreased over the last 2 decades. And the second study actually was done at the HRI with EDC too, and so that they rank people in terms of their prognosis based on the respect tool. And then the patients who fall into the category of less than 3 months prognosis, only less than a third received at least one visit from a palliative care team by a physician. So this data is a bit confounded in the sense it's not looking at nurse practitioners, and because we don't have the data to compare. But with that being said, 2/3 of patients that are in less than a 3-month prognosis did not receive any palliative care home visits by a physician. And so what we know about the patient satisfaction in home visits is that, most people, 75% of Canadians, prefer to die in the community. They prefer to have a home death or potentially a hospice death. But despite this, over 50% are dying in hospitals. And so, what we think about that is that, if we do get a physician to the home, if they've had at least one home visit, there is a decreased cause of dying in hospitals. And so what can we do to increase home visits for that reason? But also seeing that if there is home-based primary care, we see an increased quality of life, there's increased patient satisfaction, and symptoms, and that's well documented in a lot of literature. My last slide on statistics is just what, if we don't care on a patient population level, thinking about the system level, we know that home visits reduce ED visits, it reduces hospitalizations at end of life, and it reduces hospital deaths. And this really does alleviate the strain on the system. And showing that, the costs are rising. but also the number of people that are aging is rising. And so there is going to be an increased number of costs over to the system, caring for people at end of life and in the very near future. So, and so this is some of the research that's also coming out of the HRI. The first two slides there, or 2 points, was through the Eisenberg lab, and where we looked at the different levels of interventions that would help increase the delivery of home visits. And one of the main things is education, training, and mentorship. And so, you know, this is why I bring back where our PCC can really serve this role in increasing. We also know that, you know, students want home visits in their education program. And so there's 2 studies out of the US that show that like home visiting programs during residency training was emphasized, and then even the medical students expressed that if they had opportunity, they would be more willing to do it. And so because of all those things and working with the Eisenberg lab and that coming across my plate and really thinking about it, and having these like wonderful relationships with Dr. Crabtree and with the Air Family Health team, I thought, well, we thought we met and we were kind of thinking about how can we collaborate more, how can we be more upfront in the support of the primary care team to increase home visits, because the biggest thing Paul brought to my attention is that everyone was doing this off the side of their desk, like, you know, after hours, on your way home, on a weekend, in the evening, because your clinics are full and the whole day. And coming from primary care, I could imagine that. And also, I also starting to think about, you know, are there standards at the University of Ottawa or even across the universities around home visits for family medicine residents? What are we doing to prepare them to launch them into their career to be able to provide home visits? And how comfortable are they if they've never been exposed to in-presence? So this kind of led me to thinking more about this topic, and I was very, very grateful to have the opportunity to be presented with the Telfer program for benefit quality improvement, patient safety, and which is now united with the air for next year and this year. But the topic that came to mind was, you know, how can we increase home visits or palliative home visits at an academic health center? And so my aim is to increase them over 3 months by 20%. And so going back to the literature and thinking about, okay, the barriers to home visits, and, you know, these are the common barriers. And this comes from a systematic review also through the Eisenberg lab. We're looking at 52 articles. You know, we kind of came up with these specific barriers, and the themes are training, funding, support for primary care providers, and so that to give them more time and energy to provide home-based palliative care, but also time, which is a huge one, and then a lack of like role. And so, and also Paul brought up this like fear of on-call requests, which I think we slotted into the training area where, you know, if you're not getting those calls, being on call, then how are you going to be prepared in the university? And so the intervention in my quality improvement study was to create a co-design workshop with the senior family health physicians, and this was last year in January, where presented them with a survey to assess their perceived barriers and their perceived behaviors for home visits. So, and then compared them with literature around home visits and the systemic perceived barriers that we come across in research. And we talked about different topics such as like identifying palliative approach to patients who would benefit from a palliative approach to care, logistics around home visits, a lot of those forms like like Paul mentioned, expected death in the home, the palliative care facilitating access for drug coverage, how to fill out an electronic medical certificate of death, all the symptom management kits. But we also spent a long time around workflow strategies to support home visits in the clinic so that we're not doing this off the side of the desk in the future. And so in comparison, comparing billing codes 3 months prior from that co-design workshop and then 3 months afterwards, we saw that we were looking at an increase in home visits. And I will add that that was over the winter months, and home visits over the winter months is less likely. So I would even suggest that it could be higher than that in the summer months. But we did see over a 60% increase in the home visits, which was a surprising amount, but coming from potentially a low basis. And so the future aim for this project is we're coming up where we just surpassed the 1 year mark from that co-design workshop, and I hope to work with the family health team in reviewing those just like 1 year prior and then 1 year after, and to see if there's any interesting benefit from that workshop. But also speaking with other academic family health teams, because I think that though we know that education and mentorship is a big part of how we can get learners exposed to home visits, I think the biggest thing for my buck in terms of energy is speaking to the academic centers, and hence why I was very keen to take the opportunity to speak to you today. I'd also like to approach some family health teams in the Champlain region, and I since have working with in collaboration with Competence de la Community Jeunesse in the francophone population in the Eastern Township. And I'm hoping to collaborate with Paul and potentially create a home-based primary care program every year. And I'll pass that on to Paul to speak more about that.
So I hope you can hear me. I'm getting close to the mic. I think that it is a gap. I just reviewed the competence surveys of our residents, and they have indicated that this is a gap. And I'm going to be blunt. We're not doing a great job at Primrose. It's off the side of my desk after clinic, and I think we have expertise available, and the patient, it's patient-centered, and the patients would like it. So I'm going to be going on sabbatical at the beginning of April, and this is one of the things that I'm going to be working to achieve some sort of a base or clinic for the residents. Three design components and models have been identified among 9 North American interventions. These three things seem to lead to the development of a better home-based primary care model. Primary care provider leads in the potential care team. Check, we have that. The primary care provider provides after-hours support. We have that, and we also have backup of our PCP, as Jessica mentioned. And the program holds regular interprofessional care needs. This is something that we can formalize with our system. Other models in Canada include a model developed at from the family medicine academic fit, where the majority of 14 academic fits came together with Ontario Health at Home to build a network to improve access to palliative care for patients across Toronto while simultaneously. So there are resources. Learning points include embedding a home care coordinator in each fit, because a lot of it relates to communication with the home care coordinator. They also have access to consultants, including geriatricians, geriatrists, and use live video conferences, which is something I feel that we need, as well as palliative care specialists. The program is enhanced by physician assistants and nurse practitioners, especially with advanced care. Geography is a challenge for, as many of you know, having driven on the Queensway lately. So we are probably going to need to, for our teaching clinic, home care clinic, a la surgical clinic, or any kind of gynae clinic. This will be a home-based primary care clinic. We probably have to set a geographic limit on that in order for it to be valuable teaching. I'm going to skip this slide because we have 5 minutes left. These are our references, and I would open it up. I would thank you for your attention. Sorry about the technical difficulties with the sound, and open it up for any questions you might have.
Paul, Jessica, thanks so much. That was a great presentation. It reminded me actually, just a couple of weeks ago, Nick Pimlott, who's a family doc in the GTA, wrote a great editorial in the Globe and Mail, exactly on this, and referencing a lot of the statistics that you have, and really, they're, about the need. I mean, historically, this is so important. In the backbone of family medicine, the family visit, and to be able to bring that back is so important. So applaud you for this. Thanks for putting in the Kirkpatrick model. I think, in your QI initiative there, Jessica, that's great. And that you're looking, I mean, a criticism of this is that many people are using like once you get to the level of behavior change, people are still citing self-report stuff, but you've actually, you're putting in some metrics there to actually show, change in behavior. So that's great. Really glad to see that. Anyways, I will open the floor here for comments and questions. Oh, quiet group.
Congratulations to this fantastic presentation.
Thanks, Peggy.
Hello, it's Laura Vicentin. Can you hear me?
Loud and clear, Laura.
I'm sorry, I just arrived in my office. I would say thank you so much, RPCT. I would fully attest that it has been hugely helpful in helping me to be able to manage palliative care patients, particularly the ones that have chronic diseases that kind of grumble along with those occasional flare-ups, and ultimately they pass away rather than, those kind of short course, typically cancer patients. So thank you very much. My experience has been overwhelmingly positive.
Thanks for saying that. It means a lot. I think I presented a bit of this work at the Montebello retreat. And I took a lot of feedback from that session. And, I'm very humbled to appreciate that, it's not a perfect model, and that, there's always room for improvement. And from that session, I brought back to our team like the concern about overnight calls, and we've modified. And I think that, we're working in collaboration, and I'm really hopeful that we can try to fill these gaps, because not everyone is appropriate for a takeover team, but since the existence of takeover teams, and I mean like people who will take over care, provide primary care and palliative care and end of life, which like wonderful model, so helpful for people who are orphan patients or are not able to access primary care at all. That being said, if you still family physicians in the regions where it was very prevalent, and so we're seeing that very heavily in Foxbury, where there was a physician who was doing takeovers for many years, and then and the family physicians are not comfortable anymore, and so it's confidence, give them the tools and the empowerment of really, I'll show you how to do it once, I'll show you how to do it 17 times, but like I really think that this is something that you're able to provide, and I think it's also what we're telling the residents, like, oh, they're now palliative, I'm going to refer them on. I don't know, right? So, and I've worked with you, Dr. Fenton, and
yes. Yeah, I agree. I think it's also like, it's kind of the piece of the team. And I think the residents also need to know kind of what home care offers too, because they are a huge piece, like, slice of the pie as well. Like they're part of the team, and they play a huge role.
Absolutely.
Thank you.
And I did train under the model at U of T, and I have contacts, so I'll definitely be connecting Paul to them. But that model has been sustained for over 15 years. Even I think it was in existence 10 years prior to my residency. Needs a lot of funding, and so it is something very proven successful, and they're coming out of that. But
Thank you.
Thank you.
Doug, I have a quick comment question.
Oh,
if I may.
absolutely. Go ahead, David.
Hello, amazing job, Paul. Jessica, it's amazing job. Very nice to meet you. This is dear and near to my heart. Home visits. How do we define geographic catchment? I'm part of the team at CFP, and we've invited Jane Philpott to write on this issue because, in fact, it was one of the original 9 principles of Ian McWhinney. She'll be writing in July about the principle of sharing the same habitat with our patients. Not in a literal way, but in terms of understanding their context. So my question is, how do you define that geographic boundary? Is it the same as your clinic's geographic boundary as we're improving the system? We have some data showing that after about 10 kilometers, 20 minutes of travel time, using GIS, the drop off, the visits really drop off. How do you define geographic catchment, and how is it working or not working for you?
I mean, I could sort of jump in here, David. I think that's a very, very good point. It has to be practical. I would say 10 kilometers makes sense. 20 minutes makes sense. Having said that, I probably have driven further. Just know how our practices have evolved over time, and I've got patients that live in Cornwall and constant stay. I leverage the paramedics to help me with those patients if they require sort of like home-based care, and some of them do. But I think if we're talking about a teaching clinic, we have to make it efficient and fruitful for the residents. And spending more than 20 minutes in travel time each way, I think is less efficient. So I think that's a very good suggestion. I don't have a better answer for you.
I think where your clinics are located makes a huge difference too, in terms of Primrose and Elizabeth Riviere. There is concentrated mass around those clinics.
Yeah.
Even keeping it really tight, like 3K, which is the picture we showed with a 3.2 kilometer radius. That would be serving Vanier, downtown, the Glebe, Ottawa South, Old Ottawa East, and into Hintonburg. And there is a lot of population there that can be served out of those 2 clinics. That being said, the Riverside is more of there's a larger, it's a little bit more wider spread. And then if you think about Perth and Winchester and Pembroke, even wider. So thinking about your population, but even taking off small chunks and seeing, this is what I've learned at the quality improvement program, is start small, and if that's going well, then expand, right? If you start at 2K, because then you can walk or bike or, things like that, where you can rely on potentially transit. Where when I was a resident training at University of Toronto at the Toronto Western program, we would walk 4 visits with our staff, and we only did 3K radius, and that serves an enormous amount of people. So thinking about, this is different, that's a dense urban setting, but how can we adapt in these settings? But I would always encourage start small and expand than becoming too burdensome and overwhelmed.
Amazing. Thank you.
Jessica, Paul, thank you very much. As well, please, if you have any questions for Jessica or Paul or comments, please put them in the chat. Please note that we also have the session's evaluation link in the chat as well. Please take a chance to fill that in. I'll now hand things over to our second presentation, and that's by Krystal Macleod. So Krystal, over to you.
Perfect. Thank you. Okay, can everyone see my slides?
Yes.
Excellent. So I'm here today to talk to you about a tool that we've created that's in the process of being tested, and to get your feedback on how we would consider rolling this out province-wide. We're not at that stage yet, but it's coming up close. So I'm hoping that we can get some feedback on that front. So in terms of land acknowledgement, I'm going to piggyback off the lovely one that Paul did, because we're located in the same place on the unceded territory of the Anishinaabe Algonquin people. Just adding a personal note, in our research team, we actually work with the Mohawk Council of Akwesasne on this project in collaboration to figure out how we can use this tool, which does come from a Western lens, and how we can adapt it to meet the needs of the Akwesasne community living on reserve. So we have a personal connection here. This is my research team. So generally we do work that's around improving culturally informed and social care. This project I'm going to talk to you about is particularly around integrating brain-heart care for people with heart failure that are at higher risk of mental health issues. So running through the background, it's becoming more and more, people are becoming more and more aware that brain and heart conditions are interconnected. We already know that they're a big leading cause of illness and mortality in Canada. We're still struggling with the fact that we provide brain and heart care in silos, generally, definitely at the specialist level, less so at the primary care level. So we're hoping to try to move more towards a primary care model where we deal with brain and heart care in the same room with the same physicians, or at least multiple physicians in the same room. So what we did is we worked on this project in connection with two Ontario health teams, Great River and Archipel. So they cover the area from Ottawa to Cornwall. Our coalition also had patients and caregivers, and then a whole bunch of care providers, primary care, cardiology, psychology, and then allied health in terms of pharmacy. And basically what our research coalition told us is that they were mostly concerned about the fact that patients were not having conversations around mental health in their appointments for cardiac care. So when you went in to see your primary care or your cardiac care provider for a heart issue, that's what you talked about. And this idea that you are at much higher risk for a mental health issue was not brought up and not discussed. And they wanted to see movement on that. So that's what we tackled. I won't go through this in detail because this is research hat and you're probably not super interested, but we did a whole bunch of different mixed methods things to get to the point where we had co-developed a tool that could be used. And now we're in the process of trialing it. So I'll run you briefly through what we did. So what we wanted to do was establish a tool that would improve the awareness, recognition, discussion, and management of mental health in patients with heart failure. Our research coalition told us they wanted actually 3 versions of the tool. They wanted one that targeted patients, one that targeted family caregivers, and one that was for healthcare providers. And they told us they wanted the tool to do a whole bunch of different things. They wanted educational materials explaining to people that heart care and brain care are connected. They said, once we tell people they're connected, we're going to have these conversations, and that's a hard thing to have. So they wanted conversation support tools that helped each of these groups talk about mental health in cardiac spaces. They wanted asset maps, which would direct people to existing medical and community resources. They said, recognizing that there are long wait lists, especially for community resources, they wanted self-management activity maps to let people know that there were things that they could do, preventative things and management things they could do on their own while they were waiting for more formal care. And then they wanted to make sure that there was lots of training support for any primary care or other medical providers that we're asking to use the tools. So we worked really hard and developed all of these different things. So this is an example of what some of the education things look like. So the mode that everybody decided on was an interactive website. And so you start with this idea of education about the fact that heart failure and mental health are connected. It's all rooted in the literature and evidence. That was something we heard was very important. Is if we're going to tell people stats, they want to know where the stats are coming from, and they want to know that they're coming from reputable sources. So it's all evidence-based, but people can kind of navigate through this tool to learn more about how mental health and cardiac care are connected. We have all of these beautiful self-management guides that were developed over the summer by a Master's of Public Health student. So they go through 5 key areas where people can manage mental health and heart failure together. And they're beautiful. So these are linked on the website. There are conversation support tools as well. So these are tools that are guides to help care providers have conversations about mental health in a way that is feasible within very short appointment times and allows them to refer the patient easily to the website for additional support, given that you can't have hour-long conversations about mental health in primary care. At least so we've been told. So the conversation support guides look a little bit like this, where we provide an example of a prompt and then a possible response from the other person, and then directions of how you could take the conversation. So the intent is not that the support guides are used verbatim, and they're not used every single time. They're kind of to allow people to get comfortable with the idea of having these conversations and give some support to how things might go. But the intent is that eventually, after you review the conversation guides and use them a couple of times, you probably don't need to use them anymore. It just becomes part of your toolkit in having these kind of conversations with patients. So these are more examples. I'm going to jump through those. So we have this tool. We have 3 versions, one for patients, one for caregivers, one for care providers. And we're at the point where we're now testing them. We want to see if they're effective. The coalition decided that the most important thing they wanted to move the bar on was to increase patient engagement with mental health conversations. And they said, we just want patients to be talking about their mental health, whether that's with care providers or with loved ones, it doesn't matter. We just want them to be talking about it with somebody. So that was our primary outcome measure. And what we decided to do for the trial is we decided to test the tool in a whole bunch of different places. So we heard from the research team that it is most likely that these conversations will happen in primary care. But primary care is a very busy place, and we know that primary care providers are highly burdened already. So we thought maybe there are other places in the healthcare continuum that we could have these conversations as well. The Research Coalition's ideal scenario was that patients are having conversations about mental health in multiple places along the healthcare continuum. So you start the conversation with primary care, you can continue it with your cardiac specialist. If you end up in the ED, you have it at the discharge point when you go back home. And when you see your pharmacist, they're bringing it up too. And in an ideal world, we're kind of touching base in short spurts every time you touch up with the healthcare system. So to start the intervention trial, what we thought we would do is meet with each intervention site. So you'll see back here, we're testing it in team-based primary care, cardiac clinics, and cardiac rehab programs at the emergency discharge point and in pharmacies. So those are our test areas. And then in each of these sites, what we did is we met with the team there and we tried to figure out where mental health conversations are already coming up in the workflow and where they think that there is additional places to incorporate our tool to kind of bring up these conversations more likely. So we developed what are called clinical pathways, essentially, and they look really complicated. They're actually kind of interesting. So we met with each site and we basically mapped from the patient perspective how they would work through going through that site. And we figured out where the conversations around mental health are already happening. And we figured out where the tool, which is those orange parts, where those could actually fit. So whether that's a poster advertising the website or that's actually someone using the tool. And so this is one of our primary care sites, and we went through this mapping process, and you can see it extends all the way on the other page. And we tried to figure out those two things. The intent then is that once we're done implementing the tool, we'll be able to do a follow-up process map to see if the tool actually worked in the places that people thought it would work in the clinic, where it worked well, and where it didn't work and why. And that's part of the process evaluation with this tool. This is our second one, even more complicated, but you can see the mental health touch points. So that's places where they're already having conversations, and then places where the tool could potentially fit. So we're taking all of that. This is the stage we're in now, where we've done all these process workshops and we've gone through and we're collecting the baseline data to figure out how often people are having these conversations, how open they are to having these conversations. And then we will implement the tool and hopefully move the bar. So I can present a little tiny idea of what the baseline survey data shows us. And there's a couple of things that we're seeing already. As someone who works and feels very strongly about equity, we're seeing that we're not doing a great job in terms of cultural diversity. And this is a consistent thing when we're studying heart failure. It's really hard to reach ethnocultural minority groups. And we're finding that with this. So we're doing targeted outreach to these groups to try to bolster the numbers in that area. We also have hit a lot of people that have lots of education, which is interesting. And lots of older people, which is expected given that it's heart failure. And our balance of sex and gender is actually pretty good. We haven't hit any Indigenous participants so far. And then about 20% have identified as having a disability. We're not sure whether they're qualifying their heart failure as a disability or if it's a different disability. So we'll have to dive deeper into that. So when we're asking questions, how often are they actually having mental health conversations with their healthcare provider or their loved one? We're actually seeing a really high bar on the right-hand side. So about half of the people we've surveyed so far said that they've never had a mental health conversation with either a healthcare provider or a loved one. For us, that's a good thing. It means that we've hit the gap properly. They're not having these conversations, and so there's a place for our tool to be able to help. Interestingly, we ask them if they know where to find information and if they feel confident and comfortable having these conversations. And you'll see most people actually do. And that's also a good thing. It means that people are open to having these conversations. They just haven't had the chance to engage in them yet. And so I'm very hopeful that our tool is going to be able to move the bar. It seems like we're in the right spot for that. Some other interesting things that we've noted is that you'll see on the left-hand side, most people are not using community supports. When we asked why, they basically said they don't think they need them. And I think that's maybe part of the education piece, is they're either not aware of what's out there, or they haven't made the connection that what's out there can actually help in terms of prevention of mental health and heart issues. On the right-hand side, what you're actually seeing is that of the people that are engaging in preventative and self-management activities, most of those people are not just doing one thing, they're doing all the things. So if you're doing physical activity, you're also more likely to be eating well, not doing harmful lifestyle habits, doing mental health awareness and self-management. So you do have this cadre of people that are taking prevention really seriously and really engaging in that kind of all the preventative things. And then you have the flip side where they're just not doing anything. So it's interesting. It's not like you're doing one or the other. You're kind of either doing it and doing all of it, or you're not doing anything. So that's what I wanted to present to you. The questions I had for you that I'm hoping we can spend some time discussing is that we're going to, next steps for us is we're going to implement the tool. We're going to measure behavior change in terms of we want people to be having more conversations about mental health in cardiac spaces, including primary care visits for heart-related issues. How do we interest primary care providers in initiating discussions? This seems to be a sticking point. And we've heard a lot of we're already overburdened, the appointment times are very short. We don't want to raise something that's going to take us half an hour and then have to cut the patient off. So recognizing all the barriers, I would love insight into how do we frame this to get primary care providers on board when it comes time to try to roll this out beyond the regional level to the provincial level. I'd also like to hear if there are deal breakers when we're pitching this tool that we absolutely should either address or not address, because that will help us when we're trying to get people on board to roll this out in an RCT. If there are things you think we should consider when we're spreading this across the region, I would love to hear that. And if I'm missing anything, so if there are red flags in this conversation, you're like, but you haven't talked about this, please, please, please bring that up and let me know. Thank you so much for listening, and I really look forward to our chat in the next 10 minutes.
Krystal, thanks so much. Great presentation. And really a great initiative, great study. and so important, especially as we have an aging population, and we know that, of course, of elderly people, the elderly, if they're more isolated, they're more prone to depression and so on. And then there's evidence that there's a connection with heart failure as well. I mean, so vital, and I can't really speak, to how family physicians will be able to adopt that. I'll let that people on the call answer that. But in terms of scale, those process maps are fascinating, and could make great resident projects, for example, across the province. Right, as a QI initiative, for example, in a clinic, or perhaps scholarly project as well, as a way of getting in the door, right? So maybe that's yeah, feasible.
Yeah, that's a cool idea.
Yeah. So, anyways, I'll just open the floor here for folks. Laura, go ahead.
It's me. So Krystal, great presentation. I was just going to say, for heart failure specifically, there is a yearly billing code that family doctors can bill, and there is an associated recommended kind of flow sheet that people use. I just quickly Googled it. It does say it's based on Canadian Cardiovascular Society guidelines that might be a bit out of date. I'm not 100% sure, but it doesn't mention anything about mental health discussion. So that might be one avenue that you could explore.
Will do. Thank you.
Arun, go ahead.
Thanks, Doug, and thank you, Krystal. Sorry, I'm traveling, so I'm not going to put my camera on. That's okay. Great presentation. Really appreciated the thoughtfulness that you've clearly put into the design of the innovation, the intervention. But clearly, I think you're facing, the typical challenge that many people face, including many of us on the call, on how do we integrate an innovation into a very crowded and busy primary care space. So to what extent has there been further thought around the way digital tools can support the work that you're doing, right? And especially given where we are right now, and again, there's many people in our department that are looking at this, is how do we use AI tools, for example, to highlight for clinicians when it might be critical to have this conversation, to engage or interact with on the patient side, to stimulate the conversation or identify key details that might be valuable for the primary care clinician to then follow up on. So when you're thinking about implementation and scale, right, large system scale, has your team started to think about those pieces? So that's one part. And the second part is I also did see there was a lot of, well, I'll call it systems mapping, right, resource mapping. And a lot of great work there, but like all of those efforts, the problem with those is they're cross-sectional. They're just one point in time, right? So what happens 5 years from now, right? How do those maps get updated? How do those resources get updated? How do they stay current? So I know two different questions, but I think two things that jumped out to me from the presentation. Thank you.
Perfect. Thanks, Arun. So in terms of the AI tool, yes. So this is part of the back work that's feeding into the next several years of the brain-heart interconnectome, where we're looking at developing an AI hub that brings in predictive modeling, risk stratification, and then tools like this, as well as community resources. So that's kind of the next gen of this tool, is it will feed into the back end of an AI tool that should help patients, though the tool will be patient-facing as opposed to physician-facing. So I think we only get about halfway to what you're suggesting. And the system map, I hear your point. That is the ever-going tension between implementation science in a specific clinic to make it work in a unique customized clinic, and then figuring out how to move from that to scale at the provincial level and generic recommendations for how this works for everyone. So I don't have an answer to that ever-present tension, but definitely something to think about.
So I'll just, if I can follow up on that piece. So I think the predictive modeling is fantastic, and that gives us a great sort of, it alerts us, right, when something is there. But I think there needs to be a little more work on what is that interface piece with the patient and what's the interface piece with the clinician, right? So how are we going in? So how are we summarizing that details back to the family doctor? How are we? What is the conversation that's going to happen? Like, so how are you going to get the data from the patient into the model to predict it, right, when they're out of the hospital, right? So I think there's other AI tools, right, like large language models that could be used there. So again, keeping that sort of perspective as broad as you can. And in the same way, there is a lot of work happening both in within the academic zones, but also in the private sector, at creating AI-driven system maps, system navigation maps, and resource mapping. So that might be something to also look at, which is that how do you create a living, real-time update of these maps using these kind of AI tools to do that? So that was sort of, you can sort of see this being an opportunity to sort of hit both issues with one potential source of solutions.
Fantastic. Thank you.
Trish, go ahead.
Hi, Krystal. Listen, great project, great talk. I really liked it a lot. And, I've just been thinking about, there's a tension, right? I think most family doctors would like to help patients with this. So they're positively inclined. But as you said, they're busy, they're overwhelmed, and, so how do you match those? And so one of the things that struck me is, if I was in practice, I think what I would like is a screening question. And, and something very short. Like when I saw your question, it was lovely, but it was long. And I think most family physicians, if they know what the kernel is, they can adapt it to the situation and so on. But I think it would be helpful if I was in that situation, just to have like a screening question. And then, and they were talking about systems mapping, but again, a bit of an algorithm. So if this, then, okay, this is what I'll do. If that, then here are some resources and so on, so that you can kind of quickly go through that, it's sort of like that initial assessment and then next steps. So it's
excellent.
Quick.
Yeah. Perfect. I will take that back to the team. Thank you.
Well, fabulous. That's great. So I think you've got some good feedback there, Krystal. Thanks again for a great presentation. And like to thank all of you for joining this morning. Again, please fill in the session evaluation survey, and we look forward to seeing you next month. And as you can see here, we've had both Sathya and Agnes presenting. So with that, I'll wish you a good day and take good care. Bye now.